Hi, my name is Hunter Breckenridge, and today I'll be going over the NATA position statement about the acute management of the cervical spine injured athlete. So, for the introduction and objective, approximately 11,000 new spinal injuries occur per year, and it is the second leading cause of spinal injury in people under 30, which is our population for the most part, which is why this is very important to know. American football is associated with the highest risk, with 7.8 spinal injuries occurring annually, along with incomplete recovery, along with 6 quadriplegic events annually. Other sports such as ice hockey, skiing, rugby, gymnastics, swimming, diving, track and field, cheerleading, lacrosse, and baseball also involve risk. And the objective of this presentation is to provide recommendations on how to best manage cervical spine injuries in athletes. So some background: even though the risk of cervical spine injury is lower than other injuries, it is still imperative to understand the management. It involves combined efforts from a variety of healthcare workers, and it's possible to have good outcomes, but the management and seamless transfer is necessary. It needs to be transferred from the spot of the energy to a controlled medical environment in order to receive care. It is not something you can just treat on the field. So, a review of the literature: 162 articles were used to develop this position statement, and the literature supports the recommendations listed in this presentation. And this research is based on techniques that require minimal motion of the cervical spine and spinal cord. So, for the recommendations, for prevention, it's going to be evidence category C, and is to be familiar with the sport-specific causes, safety rules, protective equipment, and to educate coaches and athletes about risk rules and prevention. For planning and rehearsal, it has an evidence category of C. So you need to have a venue-specific EAP, which includes equipment, stabilization, immobilization, removal of barriers, communication with emergency medical services, and at minimum 1 annual rehearsal of the EAP and skills necessary to provide care. For assessment, it has an evidence category of A. So you want to look out for unconsciousness, altered state of consciousness, bilateral neurological findings or complaints, midline spine pain with or without palpation, and obvious spinal column deformity. For stabilization, it has an evidence category of B, and is to ensure cervical spine is in neutral position and apply manual cervical spine stabilization, being careful to avoid traction. If not in neutral position, realign the cervical spine to minimize secondary injury unless there is a decline in vitals, increased pain, or apprehension when removing the spine back into neutral. Airway, evidence category of C. Immediately attempt to expose the airway and cause as little motion as possible. If rescue breathing is necessary, the most trained provider should do the breathing, using the jaw thrust maneuver to prevent unnecessary movement. And you can also use advanced airway management if the certified rescuers are present. For transfer and immobilization, it has an evidence category of B and C. Immobilization should be provided until cervical spine injury has been ruled out or securely on the spine board or full body immobilization device. For supine athletes, lift and slide transfer is the best, and for prone athletes, log roll is ideal. For equipment laden athletes, we have an evidence category of B and C. Removal should occur in an emergency medical facility, but if you do have to remove helmet and shoulder pads together, only if it is able to be done so smoothly. A rigid cervical collar is advised before transfer to spinal board, and rescuers should be trained on how to remove face masks. At the emergency department management, as an evidence category of B and C, trained professionals should accompany the athlete to the hospital to assist in the equipment removal, and be aware of contraindications of CT and MRIs on athletes based on protective equipment if they were not able to remove it without jostling the athlete around. And then the final recommendation comes from the role of hypothermia treatment and high-dose corticosteroids in the acute management of an athlete with a cervical spine injury, evidence category B and C. The evidence is insufficient to justify use of in cervical spine injured athletes. High-dose methylprednisolone alone for acute spinal cord has been used, but has recently been questioned. Until more research is done, if you decide to use it, it is important to inform the patient or family of the risks and benefits of medication prior to use. So the take-home messages: keep up to date with your EAP and ensure everyone involved with your sports medical healthcare team is practicing at least annually. Establish a chain of command, but know it may need to shift based off the needs of the patient. Practice spine boarding, equipment removal, and loading the patient regularly. Immobilization, manual, and the use of equipment is critical until the cervical spine injury has been ruled out or the patient is secure on a spine board. And finally, I would like to leave you all with this message: wherever the art of medicine is loved, there's also a love of humanity. It is by Hippocrates, one of the founders of medicine. Thank you all so much for your time. I hope you have a wonderful break.